Hello. Today we're going to discuss the topic of Doctor, I have no blockages in my arteries. We're going to go beyond the angiogram and discuss the mystery of myocardial infarction with normal coronary arteries as well as um, similar subsets of patients. So, here's a quote from a physician. I had a patient who was told your arteries are open, and then she was given Xanax. Um, this is a conundrum. Patient had a clear heart attack. Angiogram shows clean arteries. So this clinical conundrum introduces the dilemma of myocardial infarction with non-obstructive coronary arteries or MINOCA. It's a frustrating and common scenario that challenges conventional diagnostic methods. So we can use the international definition for myocardial infarction. Somebody has chest pain, gets better with nitroglycerin, there's EKG changes, there's a bump in troponin, there's a wall motion abnormality on the echo. So they had a heart attack. Then they go and have a heart catheterization done, but they have less than 50% blockages in the major epicardial coronary arteries. So these kind of patients represent a significant challenge both for diagnosis as well as treatment. Now, this condition is neither rare nor benign. 70% of patients with angina who undergo angiography have non obstructive disease, and they represent a broader spectrum of patients with a similar pathophysiology. Granted, they may not have a heart attack, but they would have some other objective evidence of ischemia, but no significant obstructive coronary disease. 5 to 15% of myocardial infarctions are classified as MINOCA, which is a significant and often misdiagnosed subgroup. Such findings are 3 times more common in women than in men. There is a 5% mortality in these patients, and it approaches the 5% 1 year mortality from patients with heart attacks as well. So, quote unquote, normal angiogram hides a complex underlying problem. Ischemia with non obstructive coronary disease may represent plaque disruption, where non obstructive plaque rupture or erosion causes thrombosis. Ischemic event is real. Patient gets aspirin, Plavix, heparin. By the time they go to the coronary angiogram suite, there is no significant obstructive coronary disease. A second patient population could represent vasomotor dysfunction. There's abnormal vasoconstriction of epicardial arteries, epicardial spasm of the microvasculature, temporarily obstructing blood flow, giving a heart attack. For example, patients who use crystal meth or cocaine would be such patients. Finally, there's a subgroup of patients with coronary microvascular dysfunction, which is a failure of the smallest coronary vessels to dilate appropriately in response to demand, leading to a supply demand mismatch and coronary problems. So, to look beyond the lumen requires a multimodality approach. In the case of a myocardial infarction, a cardiac MRI would help diagnose infarction based on MRI findings. Intracoronary optical coherence tomography, which is the highest resolution internal view of the coronary arteries, can unmask culprit plaques. Invasive functional testing would help determine the definitive physiological assessment of the vessels. So, cardiac MRI will provide a definitive diagnosis in most cases. It has a high diagnostic yield. It provides a diagnosis in 90% of the cases when performed within 2 weeks of the event. It's crucial for differentiation and identify specific tissue patterns, um, such as ischemic myocardial infarction pattern, myocarditis pattern, and Takotsubo or apical ballooning pattern. Optical coherence tomography, on the other hand, reveals a culprit plaque when the angiogram is silent. It can show plaque rupture, thrombus formation, and thin-walled cap versus thick-walled atherosclerotic plaque. In a study of myocardial infarction, 78% of the patients had such atherosclerotic plaque in relation to their heart attacks confirmed on cardiac MRI. Now, when you're assessing function when the structure looks normal, you first exclude obstruction by angiography with or without FFR to rule out a stenosis more than 50%. To assess the microvasculature, you assess coronary flow reserve, which is abnormal if it's less than 2, index of microcirculatory resistance, IMR, which is abnormal if more than 25. You can provoke spasm by administering intracoronary acetylcholine to test for epicardial or microvascular vasospasm. Now, a combined OCT-CMR strategy identified the underlying cause in 85% of patients in the HARP MINOCA trial, and 64% of patients had a true MI, and Takasubo was in 6%, myocarditis 15% in this study. In the MINOCA trial, they took 150 patients with angina without obstructive coronary disease. Half of them underwent standard care. The other half underwent invasive functional assessment, and their treatment was guided based on the findings. If there was microvascular disease identified on invasive coronary assessment, then they got beta blockers. If it was vasospasm, they got calcium blockers. It was a mixed picture. They got either or both. At the end of a year, the patients who were treated after identifying their pathophysiology invasively had a significantly better angina score as assessed by the Canadian classification of angina. The prognosis is not uniform. If somebody has a plaque, then on meta-analysis they found that MINOCA patients with some underlying plaque had roughly a 2 times increased risk, 1.8. That's 2 times increased risk of recurrent heart attack at 1 year follow-up compared to those with normal coronary arteries. So, even the minor 20 to 30% blockages are not really minor. Now, if the diagnosis is plaque rupture or a true myocardial infarction, then the treatment is standard secondary prevention, antiplatelets, statins, ACE inhibitors, or angiotensin receptor blockers and beta blockers. If the underlying pathophysiology is vasospastic angina, the treatment is vasodilators, calcium channel blockers, long-acting nitrates, and you should avoid non-selective beta blockers. If the underlying pathophysiology turns out to be microvascular dysfunction, beta blockers such as carvedilol and ACE inhibitors consider anolozine for this standard of patients, this kind of patients. A new standard of care is emerging. The European Society of Cardiology and the AHA-ACC guideline for chest pain management do recommend CMR or cardiac MRI to evaluate all MINOCA patients to determine their underlying etiology. Recommendation for invasive functional assessment in patients with persistent angina after an uncertain diagnosis. So there's a new paradigm. Somebody has chest pain and undergoes an angiogram. If there's no obstruction, they undergo CMR, OCT, functional testing, coming up with a functional specific diagnosis, plaque, spasm, or coronary microvascular disease, and then undergo targeted therapy accordingly. Now, the key challenges are availability and cost. Cardiac MRI doesn't cost that much, but the invasive testing sure does. The need for expertise. Operators should be trained to perform these invasive functional studies. Logistical complexity, coordinating multiple tests. Cardiac MRI could be done at one location, cardiac catheterization at a different location. Then we need to refine treatments further. For instance, there was a recently published animal study in Nature where they took mice with microvascular disease and showed that if they were fed a purely vegetarian diet, then their index of angina significantly improved. Now, we also need to improve non invasive methods, advancing technologies like stress, cardiac MRI, or PET. And we need to enroll more diverse populations in order to understand this condition better. So, therefore, now we need to look beyond the lumen. MINOCA and INOCA are common, serious, and treatable. They're not benign findings and they're not benign diagnosis. A normal angiogram in the correct clinical setting is just the beginning, not the end of the investigation. A multimodality toolkit, CMR, OCT functional testing, will provide a definitive diagnosis. An accurate diagnosis directly informs prognosis, guides effective personalized therapy, and transforms patient management and outcomes. Thank you for listening. More to follow later.